So thank you guys very much. Mitch, we're going to move on to the next slide now. This is sort of a montage of pictures, and I want you to start thinking about a few themes that I'm going to focus on as we go through our remarks today. You know, in the past, we sort of used to go to work and we came home, and there wasn't as much interface, if you will, as much interaction between work and home. Unfortunately now, work and life are much more integrated than they've ever been before. Yes, we always had hazards that we could bring home, you know, someone who worked in lead who could bring it home to their children. But now almost every job has some sort of take-home component, whether for good or for bad. And this interface, this interaction really, this integration, this fit, whatever you want to call it, between work and the rest of our lives is increasingly important. Even blue-collared workers that in the past may not have had as much off-the-clock activity find themselves more tethered to technology and more continued work even after leaving a factory floor or a manufacturing facility than ever before. So physically, we take home challenges and stressors from work. Literally, we do as well. The integration of our personal self and our work self is really dramatically increasing. Because of that, we're going to make the argument today that traditional occupational safety and health approaches to safeguarding workers is inadequate. It's not enough for the broad base of challenges that workers face. Let's move on to the next slide. So why is this concept of total worker health needed? And why do we feel like it's been successful? We know that work and workplace contribute and therefore can be modified to improve our overall health and well-being. We know that there are inextricable relationships that exist between many different aspects of our lives. Many of those on the border that you see here are oftentimes heavily impacted by work and by our health. Work influences so much of our risk day in and day out. It certainly has health implications because wages are such a powerful predictor of health outcomes over a lifetime. Most of us will get our benefits for healthcare, another huge differentiator in life expectancy and quality of life, especially as workers get older. How we live and how we commute, dramatically changing and strongly influenced by the job that we have. And then lastly, our relationship with work, with other workers, with family, with our relationships that matter to us is largely dictated by work. It's a simple pie chart here, but it's quite complex. Those issues that straddle work and home are especially good fodder for the total worker health approach. For those of you who are new, and I would think it quite a few, if any of you, to the concept of total worker health, we'll move to the next slide to see the simple definition. The basis of total worker health, the foundation, the baseline, is to keep workers safe. Without that component, there is no total worker health. But we don't think that's adequate, especially for the myriad challenges that are facing workers today. So to that, we say companies should add additional workplace policies, practices, and programs, the 3 Ps, if you will, of total worker health, to grow health. And this combination of protection and health promotion leads to this concept of creating increased worker well-being. And worker well-being is sort of the holy grail of the outcome. This comprehensive measure of worker well-being is the outcome that we're most interested in improving. Doing that through keeping workers safe and adding to their health each and every day. Let me give you a quick, simple example. Imagine there are 3 companies, a bad company, one you would have no interest in working for, an okay company, and a great company. What differentiates those 3? Okay, the bad company will bring you to work, pay you for your time, and send you home at the end of the day. Because they did not keep you safe, they'll send you home with less health than when you arrived that morning. Basically, you're trading your health for wages. Obviously, that's against the law. That's not an appropriate way to treat workers. Unfortunately, it's still the case in some places today. An OK company, company number 2, they will keep their workers safe through the day. So they, for the most part, do intervene to avoid the majority of injuries and illnesses related to the work itself. So in that instance, those workers will come to the work in the morning with a certain level of health, and ideally they go home at the end of the day with that same level of health. But the best company, the one that most of us would want to work for, they do what the OK company does. They keep workers safe, but they don't stop there. They add to the health and well-being of their workers through these improved programs, policies, and practices that actually grow health, so that ideally it's possible to go home at the end of that day with more health than when you arrived that morning. That really is the promise of total worker health. Now, you say, that's great for the worker. They get more health through the job. They probably are likely to stay on the job longer. They carry that health home to their families, to their communities. But additionally, they wake up the next morning and they bring that higher level of health back to the workplace with them. And in doing so, not only does the worker and their family benefit, but so does the organization as well. Let's move on to the next slide, where we will take a look at the essential elements for advancing worker safety, health, and well-being. This is one of the seminal documents created for total worker health. And you can see in those 6 examples listed on the right what really the key tenets of total worker health are all about. And this is a compilation of more than 3 decades of work organization research and NIOSH input and work by Gloria Sorensen and Martin Cherniak and others that say, if you're going to boil it down to the essential elements that make a difference, these are some of the top ones that come to mind. Protect workers, demonstrate leadership commitment, engage workers, give them a voice. The whole move to participatory approaches is a centerpiece of the total worker health approach. Pay attention to how work is designed, not just to prevent injury, but are there ways that work can be designed to improve health throughout the course of the day? And making sure, especially as we're talking about personal health issues, that we ensure privacy and confidentiality. And lastly, this concept of integrating systems, of having HR and occupational safety and health communicate with each other and optimize their collaboration and coordination. We also know that when you integrate programming that both keeps people safe and improves other aspects of their health, you have better outcomes overall. Some of the earliest research by Gloria Sorensen from our Harvard Center looked at the use of respiratory health protection programs, respirator training programs, and smoking cessation programs in concert. And that led to increased, better smoking quit rates than either approach alone. On our next slide, we take a quick look at some of those 3 Ps that I mentioned, the programs, policies, and practices. The worker centricity to total worker health programming is prime. Paying attention to safe staffing levels and wages, optimizing leave and benefits, and this concept of more supportive supervision. We know this is an extremely important aspect of total worker health. Having fairness, equity, diversity, all of them extremely important in today's modern workplace. Attention to work-life fit. Some people call it work-family balance, work-life balance. We prefer the term work-life fit because oftentimes these are not balanced. Oftentimes one is more important in a period of life than another. It's rarely a balancing act. It usually is how we fit it together to make it work for individuals as their lives are changing. And then lastly, addressing work factors known to be causes of chronic diseases. Most of the people we serve will not die of a workplace injury. They will die of some other chronic disease. If we want to influence significantly the leading causes of death, looking for chronic disease opportunities and chronic disease prevention programs is going to be critical. The next slide looks at the total worker health hierarchy of controls. And this was adapted from the traditional NIOSH hierarchy of controls. It's obviously a conceptual model for prioritizing efforts to advance the safety, health, and well-being of workers. And it serves as a companion to that traditional hierarchy and uses much of the same language. Like the traditional hierarchy, controls and strategies are presented in order of expected effectiveness from top to bottom. We've also published a qualitative paper on this in just a recent special issue dedicated to the future of work in total worker health. If anyone would like to take a deeper dive to look at the hierarchy of controls and how it's applied in total worker health settings, I'd be happy to share that open access article for you. On our next slide, we focus on quite a broad list of issues relevant to advancing worker well-being using total worker health approaches. And we've divided in 10 or so categories here because all of these things are critical. Now, not all of them can be addressed in every total worker health intervention or program. In fact, we think there's a need to prioritize the specific needs of a working group, whether it's more safety issues, it's work-family issues, it's benefits or wage issues, prioritizing what you'll work on first based on the needs of the workers and the desires of the workers themselves. We use this, though, to cast a broad net on issues and research topics that we believe are critical to advancing total worker health. All have an important impact. All of them can make a difference if optimized. And these are areas where we also see new challenges coming down the road, where we need to proactively think about interventions to improve the risk that workers are facing. On the next slide, let's talk just a little bit about how work itself is becoming more complex. The interface of our work with the rest of our lives is only going to become more blurry over time. Largely, this is driven by technology, but it's also driven by other challenges as well. The psychosocial and the work organization demands on workers is a critical centerpiece to likely every possible scenario in the future of work. We're going to focus on some of those challenges right now. On the next slide, you can see this pretty dramatic rise in the acceleration of technologies and how they've changed over, the last 500 years or so, and how there's just such a boundless increase in the y-axis when it comes to technology. Now, obviously, this can be exciting. It may open doors for boundless opportunity, but this level of change, this evolution of technology is occurring at a pace far greater than the average human can evolve to keep up. So the question becomes, is technology driving us or are we driving it? Who is calling the shots here? And unfortunately, most technologies are designed and developed without the input of workers. In fact, it's oftentimes divorced from the psychosocial needs of anyone, whether they're a worker or not. So this, I think, represents a significant challenge to all of us as workers moving ahead. On the next slide, we look at some of the drivers of the future of work, and you can see there's a number of them, and we've highlighted technology here as an important one. This is a slide developed by Dr. Paul Schulte, one of my mentors, and he just retired actually from NIOSH. I'm sure many of you have worked with him over the years. He's going to be a great loss for us as he moves on to his retirement. But he presented this at the ICO meeting in November, and it really looks at a number of issues that are driving the future of work. But he emphasizes technology as one of the most important ones. Will we be assisted by some of this technology? Yes. Will we lose jobs because of some of this technology? The answer is absolutely yes. Will we need to change the way we skill and reskill workers? 100% yes. Will there be a threat to older workers who may adopt technology slower or not at all? Yes. So this may even lead to an earlier departure of some people from the workforce. Does it control us or do we control it? The lack of worker centricity in most technology, even when implemented in the workplace, is a growing concern. It is, if you ask workers, this is increasingly a common area for increasing stress. Anxiety about job, replacement, displacement, anxiety about, am I able to keep up with younger workers that are coming in? Am I able to learn the skills that are needed for this new phase, this new, renovation of the factory floor, for example? Am I able to keep up with all these changes? It represents a significant area of new stress for workers. Let's shift now on the next slide to talk about an additional stress that really is unfortunately impacting workplaces. And this is increasingly becoming a focus of our Total Worker Health program because it's increasingly a cutting-edge, leading-edge threat to workers in general. And this is the link between work and overdose deaths. So why are we focusing on this as a critical horizontal issue in total worker health and really in NIOSH as well? Well, there's some obvious links, and we'll get to some of the specifics. But unfortunately, overdose death is now a leading cause of death in men between 18 and 36. So in the prime of their working years, this is now a leading cause of death. That the number of overdose deaths is escalating. 70,000 per year roughly before the pandemic, 100,000 deaths per year during the pandemic. Overdose deaths are now more common than motor vehicle accidents in this country. In Massachusetts, in years 2015 and 2016, overdose death was the leading cause of workplace death. Now, yes, I did say that correctly. The leading cause of death on the job in the state of Massachusetts in 2015 and 2016 was not motor vehicle, it was not falls or struck by, it was overdose death. So this is a critical workplace issue. It's a worker issue and a workplace issue. On the next slide, we take a closer look at exploring the link between work, overdose misuse, and overdose. Not having a job at all is a risk factor. So lack of employment, underemployment, insecure employment. Having a job that most people would consider high hazard, that predisposes you to injury or illness, is a risk factor for overdose death. Having a lower wage job or a job that requires such a grueling schedule that you may need multiple jobs to earn a living is a risk for opioid misuse and overdose. Lack of certain benefits, like paid sick leave, is a risk factor for overdose death. In fact, some folks in some high-risk industries report using painkillers before going to work because of the underlying pain, knowing they will not get paid if they don't report to work. So the lack of paid leave becomes a risk factor. And we see dramatic industry and occupational differences in overdose death outcomes as well. Some of the hardest hit industries, construction, farming, other agricultural jobs, fishing, and it was construction and fishing that specifically were challenges in the state of Massachusetts. Certain support service jobs, also high risk. In some states, the risk in construction versus the average worker is 6 to 7 times when it comes to the risk for overdose death. We have developed a number of projects and products related to this. So if you haven't looked at the NIOSH and opioids website, please do take a look, because this is an exceptional set of resources that we think that will make a difference. Both tertiary prevention recommendations are there, secondary preventions, and a lot of primary prevention efforts as well. As we move to the final part of my presentation, on the next slide, I'd like to draw attention to another increasingly important driver in a tight labor market that's going to be a differentiator. A lot of workers now are looking for better work-family fit, and that's increasingly important. Obviously, when that doesn't happen, companies are at risk for greater turnover, There's more expense related to keeping it, and it oftentimes is a decision maker when workers, when they can call the shots more than ever before, they're going to be asking about this issue. So I want to draw attention to work, family, and work-life fit programs as an important intervention in many workplaces. On the next slide, I would say that in this demographic of workers, this is an even more important issue. This issue of work-life fit, of work and caregiver overlap. Low-wage workers in general not only face a smaller paycheck, but they have other unfortunate take-home benefits as well. NIOSH defines a low-wage worker as earning a weekly wage that is less than 150% of what a worker who's paid the federal minimum wage would earn. So that's roughly $10 or $11 per hour or less is a low-wage worker. That represents almost 1 in 3 workers in the U.S., and these workers face higher levels of job insecurity. Oftentimes will have forced overtime, certainly discrimination, wage theft is common, and they all, unfortunately, almost to 100%, report increases in job stress, low decisional latitude, and oftentimes higher hazard work as well. I bring up low-wage workers in the context of total worker health programs because one size for interventions does not fit all. And when an organization wants to put in place a total worker health intervention, they don't have to put the same program in place for every worker. They also don't have to even intervene for every worker. In fact, oftentimes you have more value, more efficiency to intervene for those workers who are at highest risk. And almost invariably, wages is a very quick predictor of where risk lies. It's not always absolute, but it is a very useful predictor of where total worker health interventions may be more powerful. Lower wages oftentimes equates to higher risk, both for workers on the job and away from the job. On the next slide, we focus a bit on the mental health needs of essential workers, and that obviously is extremely important as we're coming out of the pandemic. 1 in 4 essential workers have been diagnosed with a mental health disorder since the start of the pandemic. This was already on top of fairly high levels of mental health diagnoses before the pandemic. More than half relied on unhealthy habits to get through the pandemic. 1 in 3 said their mental health has worsened, and 3 out of 4 said they could have used more support during the pandemic. Compared to non-essential workers, essential workers are twice as likely to have received mental health treatment, twice as likely to have been diagnosed with a mental health disorder. 74% of them said they had unwanted weight changes. 8 in 10 said they were sleeping more or less than desired, and 40% said they were drinking more alcohol. Essential workers have been called on to lift a heavy load, and this has come, unfortunately, at a heavy price. On our next slide, because of all these challenges, I ask the question, will worker well-being finally find its day in the sun? Remember, we said that well-being is this outcome we aim to improve with total worker health interventions. Have we made the case for a holistic approach to worker safety, health, and well-being? I hope we have today. On the next slide, clearly more attention now than ever, and certainly in the future, needs to be paid to evolving psychosocial and organization of work hazards related to current and future jobs. Precarious employment is going to become more commonplace. No longer one career for a lifetime, but a compilation of multiple jobs. Oftentimes multiple jobs at the same time may become more commonplace. Periods of unemployment may be interspersed with periods of hyperemployment. This continued worry about will I have a job and will my career progress, because traditional methods of career progression with one firm or one company over a lifetime are likely not to be the case. This issue of technology and work intensification, of our stressful interactions with technology in general, and this tendency for us to be able to work more remotely. So the social isolation, the removal of what was oftentimes one of the major benefits of reporting to a workplace, the personal relationships and interactions. all those things may be threatened. That is why, again, an argument for a comprehensive approach to worker safety, health, and well-being. We continue the theme on the next slide where we talk about protecting and improving the mental health of workers. And I would argue that this is in the top 2 or 3 consult requests that come into NIOSH. How can you help us improve the mental health challenges we're seeing with our workers? Suicide risk in some workers and some industries and occupations much higher than in others. Construction, unfortunately, is another leading industry where suicide rates are quite high. Our goal, obviously, is to focus on primary prevention, not just on the AP programs, not just on better screening for depression and anxiety, but swimming upstream and changing the nature of the job, the demands on workers, the quality of supportive supervision. All of these things are going to be really important. If I had $1 to invest in a company trying to improve the mental health of its workers, 75% of that dollar, 75 cents, would go to improving the skills of frontline supervisors and managers to understand the importance of their role in creating healthier work, more supportive work, more flexible work, more meaningful work for their workforce. On the next slide, I just quickly give you a glimpse at our newest tool that the program has developed. It's called the NIOSH LBQ, and it's a comprehensive way to measure worker well-being. This is the first measure exclusively designed to measure the well-being of workers and not just the general population at large. It's free for your use, it's validated, but we need help to get this out in wider usage. We're also looking for a better way to benchmark across occupations and industries, to accumulate and share data, and to continue to develop the tool and improve its utility. We'd love to talk to any of you more about this instrument if you have an interest in using it in any of your projects or programs. On the next slide, I just close with a few words on this broader focus for not only total worker health issues, but for our field, for occupational safety and health in general. Work obviously is changing. We've made that case. You hear it a million times a day. So occupational safety and health as a profession must change as well. All of these things that we've talked about, demographics, work arrangements, technology, pace, the environment, all in flux. We believe our field needs both a horizontal expansion, understanding the interaction of exposures as work is experienced, and a vertical expansion, consideration of how these issues accumulate and influence each other over the course of our working life. And we're going to continue to make the case for this concept. This broad concept of worker well-being is the end game. It's what we really should strive for. Not just zero injury, not just zero accidents, not just zero work-related illness, but something positive. We don't want just negative outcomes. We want positive outcomes, increasing worker well-being. Our field needs to be more interdisciplinary and transdisciplinary to appreciate the learning from schools of business, from schools of public health, from schools of business, because they're all things that can be learned. Human resource professionals can bring a lot to our field here, in our view. And obviously, we see a future where building total worker health skills and professional capacity is important. My last couple of slides is just to share some resources with you. The NIOSH Total Worker Health Centers of Excellence was really happy to expand from a footprint of 6 to a footprint of 10. Martin Center, CPH New, Connecticut, and UMass Lowell is a great example of one of our legacy centers that's been with us for 15 years or so. And we're happy to add 4 new ones this round: the California, the Carolina Center for Total Worker Health and Wellbeing, Johns Hopkins Total Worker Health Center dedicated to workplace mental health, and lastly, the new one, Utah Center for Promotion of Work Equity. Really love how these centers have broadened our research base. The next slide shows our Total Worker Health affiliate network, and I'll just say thanks to those in the New York, New Jersey area, including the University of Rochester, Madison County, New York, University of Buffalo, and Mount Sinai Health System. We really appreciate the affiliates really are on-the-ground learning laboratories, and we're extremely pleased with the contributions that they've made. The next slide is a reminder that we have a textbook in Total Worker Health, and this is used in many of the 6 academic certificate and degree programs now offered in Total Worker Health. Be happy to talk to you more about those if you have any questions. And then lastly, I'll invite you to connect with us on our various social media and subscription services. Total Worker Health in Action is our e-newsletter. It's all the way to the right of those 4. If you're not getting that, you're missing out on a lot of great resources. Not only do we highlight all the research coming from our 10 centers, but we highlight promising practices in private sector organizations, and we feature all the learnings from our affiliate network as well.